All right, so now it gives me great pleasure to introduce Professor Jonas Nilsson, who is the current Professor of Melanoma Discovery at the Harry Perkins Institute and Professor in Experimental Cancer Surgery at the University of Gothenburg in Sweden. So Jonas is also another incredibly pivotal figure in the field of melanoma research globally. Initially trained as a molecular biologist in the Umeå University in Sweden. I hope I'm pronouncing that correctly. My Swedish is not very good. And then as a tumor biologist at the St. Jude's Cancer Research Institute in Memphis. He was a fellow of the Swedish Cancer Society from 2007 to 2020 and became a full professor in 2015 and director of the, I'm definitely going to pronounce this wrong, Sahlgrenska Cancer Center from 2018, and in November 2020 took up the chair mid-COVID of the Melanoma Discovery at the Harry Perkins Institute of Medical Research, where he's done an amazing job and is building a multidisciplinary translational research group that works with melanoma clinicians. He has published extensively in numerous high-impact journals, Understanding Melanoma, including Nature Communications, Oncotarget, Nature, Nature Medicine, Nature Again, Cancer Research, and contributed to a number of practice-changing studies in uveal melanoma, which he will outline for us today. So thank you very much, Professor Nilsson.
Thank you very much, Anthony, for that very kind introduction, and thank you very much to the organizers for giving me the opportunity to give a very brief and a preclinical scientist's view on current treatment of metastatic uveal melanoma ongoing in my group together with my clinical collaborators. So we have already heard a very nice overview of some ongoing exciting work in this field, which is really exploding in terms of clinical trials and also understanding of the disease. We all know that the metastatic disease happens in about 50% of the patients, mainly to the liver. And there's genetic causes for this, most often mutations in BAP1, but also some other copy number alterations that we found, which are enriched in metastatic disease. But as we all know, the metastatic disease lack efficient treatment. So all of these therapies depicted here on the right are being provided to patients based on their disease progression. And of course, we also just heard the very exciting news about the T-cell engagers and the tebentafusp that will be called Kimmtrak as a drug, which can prolong overall survival. But we also heard now about the side effects from these drugs, and I'm really hoping that this will spawn a lot of interest into understanding those side effects so that they can be managed, just like all the issues we had initially with the immune checkpoint inhibitors and how they are today used regularly in skin melanoma clinic. So today I will give primarily updates on trials and actually preclinical activities ongoing in local regional therapies, immune checkpoint inhibitors, and cell therapy. So starting with local regional therapies, of course, quite relevant in uveal melanoma, since it's so confined to the liver in many of the patients. So there is a method that's been ongoing for 40 years in the clinic called isolated hepatic perfusion, where the liver is perfused with very high doses of melphalan that wouldn't be tolerated if given systemically, but if it's given to the liver, it is tolerated very well. And a retrospective analysis from Gothenburg that had shown that isolated hepatic perfusion actually seems to prolong life of patients quite dramatically when compared to historical controls. So Åge Olofsson Bagge, surgeon, decided that it was time to actually try this in a randomized trial to actually tell the world that this therapy seems to be working, or to stop using it if it turns out that it doesn't really work. So what I will be presenting today is data from the Scandium 3 trial, which now actually have the secondary outcomes ready for public disclosure, and that's the secondary outcomes of the progression-free survival and overall response. So this trial was a randomized phase 3 trial comparing perfusion to best alternative care in patients with metastatic uveal melanoma. So the patient could either get IHP or any type of drug, including checkpoint inhibitors. So 147 patients were screened. Out of those, 90 patients were treated at the various centers in Scandinavia. They were recruited there, but they were all treated at one center in Gothenburg by Roger and his colleagues. So here's then the progression-free survival. And this is the secondary outcomes that were just presented at ASCO, where it was a poster discussion. So the 6 months progression-free survival rates were 58% for the perfusion group, but only 8% in the control group. A median progression-free survival was basically doubled in the IHP group. And if we went into specifically the hepatic PFS, we saw that the survival PFS was basically tripled by providing perfusion. There were quite a lot of responses, very deep ones, even 3 CRs in the perfusion, whereas none in the control. There were 14 partial responses, whereas it was only 2 in the control, and an additional amount of stable disease. There were side effects in the IHP group, slightly higher, mostly related to the surgical procedure, but overall not dramatic. So what about the control group? To just look a little bit more what these actually received. So 7% received anti-PD-1, 9 IPI. Ipi-Nivo was provided to 16%, and pembrolizumab entinostat was given to 7%. And you might be wondering, what is this pembrolizumab entinostat? And that's actually, since the best alternative care arm didn't really have good options, we decided to do some additional research into uveal melanoma for the last 8 years. And we came up with a concept that we should try to see if we could modulate the epigenetics of uveal melanoma. And we came up with that histone deacetylase transferases could be a potential therapy for uveal melanoma, being it that it can enhance antigen presentation in cancer cells. So we had investigated this in uveal melanoma in vitro, where we could show that HLA could be induced by entinostat in different uveal melanoma cell lines, but it also induced PD-L1. So then that gave a rational combination of entinostat plus PD-1 inhibitor. We also did some additional studies in vitro where we treated uveal melanoma cells with TILs and provided them with entinostat, and you could see that there was a synergistic killing of immune-mediated killing with entinostat, also providing additional preclinical evidence for this trial. So the trial was then the PEMDAC trial, which were carrying out in 4 different sites in Sweden. It's an open label phase 2 studies where all patients received entinostat as a tablet or pembrolizumab injections. And primary endpoint was overall response rate, where we assumed that the pembrolizumab alone would only give around 5% response rate. So if we had 4 responders, it would be a positive trial. So what I'm showing today will just be an update of this trial, since it was actually published already last year with the data that 4 partial responders out of 29 patients who made it a positive trial. Progression-free survival was very short, but the overall survival, 13 months, was a little longer than historical control. There were a correlation with tumor load. So if there were high LDH, high ctDNA levels, then that connoted shorter survival. We also had a patient with iris melanoma and a high mutation load. That patient responded. and patients with the wild type BAP1 gene appear to survive longer than patients with BAP1 mutations. So now I'm just going to present the 2-year data, because in the Nature Com paper it was 1-year data, and here you can see that we have still patients that are alive in this trial. Currently there are 7 out of 29 patients alive 4 years after trial, and this is then actually 3 out of the 4 responders who seems to be connected to the genetics of the patients. So going back to the perfusion, so to be able to maintain the treatment perfusion at the clinic, an additional trial had to be started, and this was actually a combination trial with perfusion and then Ipi-Nivo, and Ipi-Nivo came from that this treatment itself seems to have some activity. So this is an ongoing trial where at least half of the patients have been recruited. So we'll have to provide an update about that in a year's time or so. One of the good things with the perfusion treatment is that the liver is actually exposed to the surgeon during this procedure, and this means that samples can be collected, and we have of course then being able to generate a live biobank of uveal melanoma, which we're using to generate PDX models and to study the genetics of the disease. And we had this publication 2 years ago where we looked at around 30 metastatic melanomas to find that iris melanoma can be UV damaged, that BAP1 mutations are more common than previously thought. It was actually in 90% of the uveal mets had a BAP1 mutation, some of them in introns even. That BAP1 can regulate class 1-2 switches, and that some CNV and loss of CDKN2A are recurrent in mets. And we also analyzed tumor-infiltrating lymphocytes from this live biobank, and we are continuing to use them. And we found that some of them clonally expanded, expressed not only PD-1, but rather TIM3, TIGIT, and LAG3, as was mentioned also during Paul Nathan's talk. So that was this publication in Nature Com. And we have been continuing now to work with this biobank where we generate patient-derived xenografts. And unfortunately, these mouse models are problematic because the tumors grow much slower than the counterpart of the skin melanoma. So we have realized that it's very difficult to do therapy studies in these mice. So instead they are used as a bioreactor to maintain very, very viable and good uveal melanoma cells. And from these PDX tumors, we actually generate spheroid cultures that we then can do drug screens and do therapies with TILs that we have also autologous TILs grown out of the tumors and match them in vitro to look at immunotherapy of uveal melanoma. And here's just one example where we have mixed autologous PDX generated spheres with TILs and can look at activation markers, and we see that some of these patients' TILs can actually get activated by just meeting their tumor. And in these 2 cases here, we actually generated also PDX models that grew at an acceptable rate. And in this case, wherever this tumor is actually activated in vitro, it can also completely eradicate the tumor growing in a mouse. Whereas if the tumor is not being activating the TILs, then the TILs are no longer as efficient in mice. So there seems to be a good rationale for using this sphere TIL experiments to discover new ways of improving TIL therapy. So TIL therapy has been used in uveal melanoma in small studies, and where this is an example in 2017 where they did have CRs and partial responses to TIL therapy. And we're of course interested in taking this further into the clinic. And in Sweden, we are We have registered this trial that we are submitting to the Swedish TGA very soon. It's a phase 1 study where we're using a bioreactor to generate TILs from uveal melanoma patients. And it's a 6-patient dose escalation just to get this all set up. And we're going to do local administration of TILs using hepatic artery infusion methodology. And we're using, of course, melphalan then as a preconditioning IV intravenous infusion, since we know melphalan has some activity in IHP. And then we're going to provide IL-2 to the patients after infusion of the TILs. This is going to hopefully start within the year. We've been working quite hard to set up a GMP laboratory and had some problems with changes in the leadership at the hospital GMP lab. So now we've sorted those things out and hope to be receiving an approval to start this soon. But what's good with this trial is also that the protocol that we have developed in Gothenburg is also possible to move over to Perth and Australia for Australian patients. And therefore I have set up a collaboration with the Cell and Tissue Therapy WA, CCTWA GMP lab at Royal Perth Hospital, which have a new director, Sladibor Velikovic, and together with Peter, our medical oncologist, we are now planning to do TIL therapy in Perth as well. So this is a facility which has all the accreditation possible for generating products for people. So I hope that we can move along starting our first TIL trials in Australia soon. And the just last piece of the therapies that I would like to discuss is our work on CAR T therapy, where we are identifying targets for CAR T using bioinformatics and using these mouse models that we have developed to test them, and developing protocols for the automated bioreactor. And our first experiments were published in Cancer Research, where we found, rather surprisingly, that HER2 appears to have a very decent expression of in both skin and in particular uveal melanoma. And we did some experiments both in vitro and in vivo showing that we could use HER2 CAR T cells to kill uveal melanoma, and that was completely dependent on HER2 expression, which you can see here in these experiments where we have knocked out HER2 and then the TIL activity is no longer, or the CAR T activity is abolished. So this is also a line of investigations that we are trying to push forward to the clinic in Gothenburg and Perth. So with this, I'd like to thank the group that is diminishing over in Gothenburg, especially Lars, oncologist, Lisa, the senior scientist in the group, and also Roger, the clinicians, Rebecca and Samuel, who's doing the GMP studies, and Bas, who's doing the preclinical work on uveal melanoma, and Elin on the HER2 CAR. Also, this is a new, the Melanoma Discovery Lab at Perkins, where 3 of the people from the Gothenburg lab has translocated over to Perth, and we have Jessica and Navata working on PDX models and the biobank. And here's just an acknowledgement of all the clinicians and the clinical collaborations and the Western Australia Melanoma initiative that we're setting up now to broadly discuss ways forward for initiation of clinical trials and exciting research projects in Western Australia. So thank you very much.
Yeah, thank you so much, Jonas. We'll save questions for after David's presentation. So I'm going to introduce the next speaker, which is Dr. David Eschelman. David is a professor of radiology at the Sydney Kimmel Medical College of Thomas Jefferson University. He's also co-director of the Interventional Radiology and the Metastatic Uveal Melanoma Multidisciplinary Center at the Thomas Jefferson University Hospital, where he obviously specializes in the treatment of patients with uveal melanoma metastases to the liver. So he's giving us a pre-recorded talk.
Good morning. Thank you for including me in this meeting, and I'm sorry that it's via recording. If nothing else, hopefully it'll at least provide you with a cure for insomnia. I'll probably be falling asleep around the time that you're listening to this. I'll be discussing liver-directed treatments for patients with uveal melanoma. I've included a lot of slides for reference. I certainly won't be reading them all. We see approximately 10% of the patients in the United States with liver metastases from this very rare and aggressive disease. We have a weekly multidisciplinary conference and clinic dedicated to MUM patients, and we perform more than 650 hepatic embolization procedures per year for MUM. I'm very fortunate to work with medical oncologists who understand the value of liver-directed treatments in the absence of more beneficial systemic therapies, though that landscape is obviously changing. This likely isn't news to this audience, but this patient with these big bulky tumors had a normal MRI 6 months earlier. This is a patient who had this very small tumor identified. She was being followed at an outside institution, was told to get a repeat MRI in 3 or 4 months. 4.5 months later, shows up with this, and it had grown to this huge tumor by the time she started treatment with us. These patients are well suited for liver-directed treatments since their clinical course and survival are generally dependent on the status of their liver tumors. These tumors tend to derive their blood supply from the hepatic arteries, while the normal liver will still be perfused by the portal venous system. This audience is certainly familiar with this German experience treating these patients with ipi-nivo. To offer a different perspective from outside of the field of medical oncology, I can't imagine my procedures being considered acceptable with these levels of toxicity, or if almost 40% of patients had to discontinue therapy due to the side effects. It's also worth noting one sentence in this paper acknowledging that almost half of the group also received some form of liver-directed therapy, but there wasn't any further elaboration on that. So what's the justification for liver-directed treatment? The Mayo Group has shown that patients who received some kind of liver-directed therapy, including surgery, ablation, radiation therapy, or embolization, had a survival of 26 months from the time of diagnosis compared to those undergoing systemic treatments available at that time, who survived 9 months after diagnosis, though admittedly the patients receiving liver-directed therapy were in somewhat better condition. We've looked at our experience divided over these 3 time periods that are listed. Patients in cohort 1 received mainly chemotherapy as a first-line treatment, whereas the latter 2 groups received liver-directed treatments. While there could be an argument for better detection of liver metastases and lead time bias with the more recent patients, all 3 groups were similar based on characteristics of the primary eye tumor, such as size and location. Not only has survival after starting treatment to treat the liver metastases improved, but these treatments have presumably been the reason for extended survival after treating the primary eye tumor. This directly contradicts the experience published about 3 years ago from Mass Eye and Ear, which showed no significant change in survival over the past 4 decades. And perhaps that's why patients choose to travel to Philadelphia. Immunoembolization, radioactive microspheres, and chemoembolization are our mainstay liver-directed treatments for this disease. This table offers historical perspective regarding chemoembolization as treatment for this disease. Except for this experience from MD Anderson, which I'll review later, note the small number of studies with relatively small numbers of patients over more than 2 decades. Also note the relatively poor outcomes. Immunoembolization is our mainstay treatment for patients with limited disease. The rationale is that destruction of the tumor by repeated embolization would control progression locally and provide tumor antigens to the local immune system. Simultaneous use of a cytokine will induce an inflammatory response in the tumor and surrounding tissues, which may help improve antigen presentation to the local immune system. This may result in a systemic immune response against the tumor cells, which could potentially create an in situ tumor vaccine. We conducted a phase 1 dose escalating study. Tumor burden was less than half of the liver. Patients underwent alternating lobar hepatic artery embolization every 4 weeks using GM-CSF, emulsified and Lipiodol, followed by gel foam slurry, with imaging after every 2 treatments. A third of the patients had a response, and another third had stable disease. This overall survival of 14 months is favorable compared with that chemoembolization table, and this was our initial experience more than 15 years ago. Here's an example of an early arterial phase image before immunoembolization and 2 months afterwards, where you see the tumors have largely been devascularized. This is the same patient with a later phase arteriogram before immunoembolization and when he returned for repeat treatment 2 months later. We learned that high-dose immunoembolization delayed onset of systemic metastases compared to lower dose treatments. When comparing high-dose immunoembolization with a comparable group of patients treated with BCNU chemoembolization, the high-dose immunoembolization patients had a longer overall survival and delayed onset of systemic metastases, suggesting a systemic immune response. This led to a randomized, double-blind phase 2 trial. Patients were embolized using Lipiodol and gel foam slurry with or without GM-CSF. Patients were stratified by the amount of tumor in the liver. Both treatments were well tolerated. Our control was not a control because bland embolization also induced cytokine production, but this was much more prominent after immunoembolization. There was an overall survival benefit in patients with 20 to 50% tumor replacement of the liver. But unfortunately, we saw a paradoxical response for patients with very limited disease. So it took us 15 years to figure out what we think is the appropriate dose for GM-CSF for immunoembolization. Patients undergoing immunoembolization showed a significant and rapid increase in production of several cytokines. Please recognize that this was a double-blind, randomized trial comparing bland embolization to drug plus embolization, showing a benefit of adding the drug, which is unique in the realm of interventional radiology. A subset of patients undergoing immunoembolization experience a prolonged survival. Okay, so some of these tumors are certainly larger, but this is over a period of 7.5 years where this patient underwent intermittent immunoembolizations, and the tumor growth occurred during the time of his treatment breaks, some of which were as long as a year. He was actually the last patient to enroll in one of the GP100 trials and is still alive. We've learned that 16% of patients treated with immunoembolization will survive more than 3 years and undergo treatment breaks. We've investigated combining treatment with immunoembolization and ipilimumab. The addition of ipi didn't prevent eventual development of extrahepatic metastases. While it's safe to combine these treatments, significant toxicities from ipi were encountered. Unfortunately, a third of patients progress despite treatment with immunoembolization. So let's move on to some other treatments, and we'll focus on our phase 2 prospective trial using Surspheres in 24 treatment-naive patients and 24 patients whose tumors progressed after immunoembolization. 3/4 of the patients in the treatment-naive group had less than 20% of the liver replaced by tumor. 87% of these patients had stable disease or better for a median of 8 months, with an 18.5-month median survival. All patients eventually progressed with development of new liver metastases. The group with progression after immunoembolization also had limited tumor burdens. While the disease control rate was not quite as good, it's worth noting that median survival was more than 2 years following the initial immunoembolization treatment. Initial data from the CERTAC trial were released at ASCO. This randomized trial compares radioactive microspheres to chemoembolization using cisplatin. Back in the 90s, we were not able to demonstrate a benefit to chemoembolization using cisplatin. Interestingly, the progression-free survival in the liver using radioactive microspheres is basically the same as we saw in our treatment-naive group using radioactive microspheres. This is a small, prospective, multi-center trial assessing the feasibility of treatment with Cerciers followed by Ipi-Nivo. Unfortunately, there ended up being 3 even smaller groups with differences in their treatment regimens. Due to toxicities in the first group from both the Y90 and the ipilimumab, the radiation dose was reduced for subsequent patients, such that the normal liver wouldn't receive more than 35 gray, which is our standard at Jefferson. The Ipi dose was also reduced. The nivolumab dose was increased in the third group. The treatments were better tolerated with these adjustments, but outcomes were affected by the toxicities. Unfortunately, this treatment is no panacea either. Let's review chemoembolization, starting with this large experience from MD Anderson. 125 patients mainly received chemoembolization using cisplatin, but half of the patients were also treated afterwards with intra-arterial chemotherapy infusions. It helps that the patients are stratified by tumor burden. The high complication rate was attributed to the chemo infusions. Unfortunately, survival was rather dismal for patients with more than a quarter of their liver replaced by tumor. We looked at 50 patients presenting with at least half of their livers replaced by tumor who were treated with BCNU chemoembolization. Our results were a bit more promising than the MD Anderson data, and 22% of patients survived more than 1 year. This is an example of a patient with an extensive tumor burden who survived more than a year with treatment using BCNU chemoembolization. We've used drug-eluting beads and adriamycin as the initial treatment for patients with large, well-circumscribed tumors, followed by BCNU chemoembolization. This doesn't work well for patients with infiltrative tumors. But despite having really big tumors, we've seen an impressive survival, and again, note some of these long-term survivals. This patient lived almost 5 years after initial Deb-Dox treatment, followed by BCNU chemoembolization. Let's move on to percutaneous hepatic perfusion. In PHP, a high dose of melphalan is infused throughout the liver, the hepatic vein outflow is captured, and the blood is pumped through proprietary filters from the inferior vena cava before being returned into the systemic circulation. Here is a picture of their double balloon catheter with all the side holes to extract the blood from the inferior vena cava, and a good example of an isolated inferior vena cava. This balloon is sitting between the right atrium and the inferior vena cava, and this balloon is just above the level of the renal veins. Here's the catheter infusing the melphalan in the hepatic arteries and the inferior vena cava and hepatic veins. Initial results from the FOCUS trial were reported at ASCO. This started as a randomized trial comparing PHP to best alternative care. 78% of the best alternative care patients received some type of chemoembolization treatment. Note the difference between these 72 patients who received at least one treatment and the 85 patients who were randomized. That's because patients dropped out when they were randomized to the best alternative care arm. The trial was therefore changed to a single-arm PHP trial. Disease control rates and survival are quite favorable, but this is a lot for patients to undergo. Thankfully, there were no deaths from PHP in this trial, and the duration of response is impressive. However, this requires a lot of personnel, a highly skilled anesthesiologist to deal with the dramatic blood pressure changes, a perfusionist to manage the veno-veno bypass, and an overnight stay in an ICU. This procedure is a lot more involved than other percutaneous treatments we've been discussing with a similar survival. The Scandium trial, reported at the recent ASCO meeting, randomized patients to isolated hepatic perfusion, which is the older one-time surgical approach via laparotomy versus best alternative care, which consisted mainly of systemic chemotherapy or single-agent immunotherapy. It's not clear that this will be more favorable than the PHP. There is a role for ablation, particularly in patients with oligometastasis, or the occasional patients with what we call a rogue tumor, one tumor that continues to grow while the others remain stable with a different liver-directed therapy. And this is a patient who started immunoembolization in 2012, underwent microwave ablation of one tumor in 2016, and she remains alive, doing well, and hasn't undergone any immunoembolization treatments for several years. So what are we going to do on Monday morning? We don't know yet if immunoembolization or radioactive microspheres is a better initial treatment. It is our hunch that immunoembolization may be more beneficial, particularly for patients with very limited disease or if there's already extrahepatic disease. For patients with big, bulky tumors, DebDox. For patients with a lot of tumor, BCNU chemoembolization. We're also exploring use of a higher dose of BCNU chemoembolization. Our trial assessing the safety and efficacy of ipi-nivo with immunoembolization was limited by ipi-nivo toxicities. Our colleagues in Sweden are evaluating use of ipi-nivo after isolated hepatic perfusion. Future trials should compare results based on the tumor burden, genetics of the primary tumor, and for large tumors, the pattern of disease. Also, for liver-directed treatments other than perfusion, recognize that only one lobe of the liver is being treated at a time, so there's a delay in treatment of the second tumor, which could allow some tumor growth. Thank you very much for allowing me to participate in this interesting meeting.
Thank you very much, David, albeit not in person. Jonas is online, and I will put out the questions to Jonas initially. Jonas, there was a question about what are promising targets for CAR T therapy in uveal melanoma, and what sort of trials do you think that we will need to get going in an Australian context, combining both liver-directed therapy with systemic drugs?
Yeah, so thank you for those questions. Actually, when it comes to different CAR targets, this is something we're analyzing, of course, bioinformatically to see what could differ melanoma from not only healthy tissues, but other also differences between uveal and cutaneous. We're not really done with that analysis as of yet, but it does point to certain like lineage-specific proteins that can be also on the surface, including components of the melanosome has also been entertained in terms of antibody-directed therapies. I think there is a small, I would say, benefit of CAR T versus the antibody therapies, and that's like just, you know, without any other type of therapy that activates the immunity against the tumor, is that you have a drug that is living and is actively pursuing the tumor 24/7, as opposed to when you're using antibodies that can have a limited half-life or also a limited ability to reach into tumors. So I think targets that have been previously abandoned in the context of using them as as antibody therapies can be kind of repurposed in the CAR T era or also in the ADC era, I would say. So I think there's going to be a lot of activity now, not only in uveal melanoma, but also skin melanoma, now that we have started to understand how many patients fare very, very well from immune checkpoint inhibitors also in cutaneous melanoma, and understanding now that there's still patients needing new lines of therapies. So that's going to be activity in that. And then when it comes to the other question, which was combining liver targeted therapy, yes. So it all depends on if there are liver clinicians, liver surgeons, and other types of interventional radiologists that want to take on liver-directed therapies. What the abilities to do this is in Australia is. So I'm not aware if there are any active perfusionists around in Australia at the moment, but I'm very well aware that Roger, who is running the IHP trial in Sweden, he will be coming visiting, and he's of course very helpful if there is a need to set up perfusions in Australia to get some tips and tricks about that. I personally find perfusion therapies, not only IHP but also percutaneous hepatic perfusion, as a very, very good adjuvant for increasing just the ability for immune system to react onto the tumor. So to combine liver-directed therapy with tebentafusp would be an alternative, absolutely, but that would still be only for the HLA-A2 patients, but also as the preconditioning method of choice for TIL therapy or CAR T therapy, to first give a liver-directed clearing type of therapy to allow more active cell therapy, I think will probably be a way forward, and that we will try in Sweden and in Australia if there is availability of perfusionists and liver surgeons that want to take on this task of setting it up. So maybe you know more about that, Anthony, than I, in terms of, and you, Damien, in terms of the availability of liver surgeons.
So in terms of, well, certainly in the Sydney context, we have, we had 2 units, now 1 unit that gives actually intrahepatic photomustine, because it's cheap, and it's we have an interested interventional radiologist, but nothing fancy. And in Brisbane, my understanding is that it's just not done. In Melbourne, I don't know, Damien, if the team at Peter Mac, and also SIR-spheres. So the team will do SIR-spheres, and they'll do intrahepatic photomustine for uveal melanoma. The SIR-spheres are generally not, it might be covered under private insurance, not under Medicare. Obviously, the photomustine is. Damien, I don't know what the position is in Melbourne.
I think the last time I used intra-arterial hepatic photomustine might have been 8 years ago. So the individual components of each member of the team, the interventional radiologist, perfusionists, and surgeons who are capable of doing isolated infusions, they're all there. It's just putting them all together that hasn't been done. So I think if there was an interested interventionalist, then certainly the components of the team are there.
I think also an important point here is that we need the overall survival data, which we will have in around February of next year. We will have the 2-year overall survival data. The PFS does look extremely, extremely promising. I mean, a triple in PFS is very good, but on the other hand, and also the PHP had similar numbers, but the overall survival is still the thing that makes it tipping it over in favor of actually really starting to use his therapy globally, I think.
Yeah. Jonas, interested in, I guess, perfusion and immunotherapy. So I guess perfusion delivering cytotoxic chemotherapies, of course, helps to limit systemic side effects, allows you to give a bigger dose. What dosing considerations do you have to think about for things like ipilimumab and nivolumab or tebentafusp when you're giving it in a perfused manner?
We are not perfusing ipi-nivo.
That's
given,
okay.
No, that's given systemically. Yeah. Okay. I do believe the lower concentration of ipi, but I think otherwise it's not liver directed.
Okay.
Okay, well, we've probably got 15 minutes to the break. I just wanted to say thank you to our sponsors and name them. So Bristol Myers Squibb, Immunocore, Eckert and Ziegler, Novartis, IDEA Pharmaceuticals, Peter Mac, and the University of Sydney Safe Society Institute have all been critical to allowing this event to continue, and we appreciate their support to advance both the science and the patient care in this manner. So we've got now a break till 11 o'clock for some morning tea, everyone to go and stretch their legs, take a bio break, and then we've got a very exciting session with an ophthalmology focus coming up, which will be chaired by Dr. Rod O'Day and Dr. Claire Phillips. So very much looking forward to that. So Damien, correct me if I'm wrong, but everyone can just have the next 13 minutes off and look forward to seeing you all at 11 o'clock.